regardless. So as many of you mentioned in the survey, we do have a decent amount of experience among members with community listening sessions, but for those of us who don't, and for our listeners, let me quickly explain what a community listening session is. Unlike a focus group where the conversation is structured more rigidly around a specific set of questions, Office of Minority Health and Health Disparities Prevention community listening sessions engage our participants and provide them with an opportunity to drive the focus of our conversation as well. Our facilitators are made aware of our goals and the topics we'd like to discuss so they can keep the conversation heading in the direction we need it to go. But the structure provides an opportunity, like one of our council members mentioned in the survey, to identify where our gaps in understanding are about the needs of the community and what their priorities are. It's a less limiting way compared to some other data collecting formats. As the discussion is taking place, we would ensure that feedback is recorded so we can conduct an analysis of our responses and use that information to help inform the recommendations that we make to the commissioner. As I've discussed before, the council's charge includes, but is not limited to, consulting with patients with sickle cell disease, their families, and healthcare providers specializing in treating sickle cell disease, among others. And to gather this information, you all have expressed interest in using the community listening platform. One hallmark of an OMH-HDP community listening session that I would like to highlight before moving on is the emphasis that we place on follow-up. A community listening session requires a level of vulnerability from our participants that we need to acknowledge and respect. In addition to the tone that we set during our sessions, we need to prove to our participants that their perspectives are heard. So by sharing a summary and action steps or whatever else you find appropriate, it keeps our participants involved and in the know about the information, how the information we collect is being used, which is why, I asked about follow-up specifically in the survey. She is? All right, but I'm happy either way. Do you have any time constraints, Sue?
No, go ahead, you can finish.
Okay, thank you. So, now, when I asked council members about what a successful community listening session would accomplish, you all said that it's important we get a variety of answers from our audience. We'd obtain information on the needs of consumers and providers and what is most important to support care. We'd approach the session with clear goals, record responses, stay on task. We'd get a high response rate and provide incentives. We're going to put a pin in this. An incentive for attending a meeting is not something DOH can do, but I want to make sure we understand what we can do. When we have, we would have a focused outreach in these sessions. So we're listening to a broadly representative population of impacted folks. We'd seek out voices from, rural places while not overcorrecting our findings. We would receive actionable feedback from our community members, and we would have both process and product outcomes, including the outcome that individuals feel considered and heard. We would collect qualitative data that can be analyzed to identify major themes of the questions or research we're pursuing. From these responses, I see that we have a need to establish who exactly we'd like our participants to be in these sessions and why. And please let me know at the end, especially if you didn't get a chance to answer the survey, if you think of anything else that's essential for a successful community listening session to accomplish. When I asked the council members about how many listening sessions we should hold to fulfill our requirement, most answered 3 and 4 sessions, though we did have a range in responses, some fewer, maybe an acknowledgement that we're operating with limited resources, and some greater, noting a concern that we want to involve as many people as we can to have a representative sample. And as we begin planning, it'll be important to discuss where that balance is. Regarding the number of participants in each session, we also had a range of answers from as low as 5 in a session to as great as 35. When asked about when you all would like to begin community listening sessions, most of you indicated May or June. Our ability to get this in motion will depend on the progress we make today and the budget when that is being signed for DOH, which we'll keep you posted on. Regarding the time that would be best to hold a community listening session, most of you landed on 5 to 7 p.m. Some of you indicated we can consider 11 a.m. to 1 p.m., 1 to 3 p.m. in the afternoon, and one of you wrote in we should consider weekend dates as well, which I appreciate. When asked about when sessions should be held, we got the most support for New York City, Albany, and virtual locations. Several of you expressed interest in Buffalo and Syracuse as well, closely followed by Rochester. And I had someone write in Long Island, which I appreciate. As many of you remember from the hemoglobinopathy specialty care center map, there are several locations there as well. There was also a comment that virtual sessions will be critical in reaching our rural populations. Regarding the importance of hosting at least one in-person session and one virtual session, almost all of you stated that this was very important. Regarding participant recruitment, many of you stated we should do so through your outreach networks. A few of you wrote in social media, and I also see healthcare providers, schools, NAACP mentioned. Follow-up, like we discussed, mention the options of reaching out via email, letters, mail, phone calls, and follow-up surveys. Creating a listserv to follow up with emails was suggested, and it was also mentioned that we should make sure that the method we use can serve as a line of communication so they can come back to us with any additional feedback that they might have. When asked about the requirements of the legislation that you'd like addressed during these listening sessions, most of you answered that we should consider these questions. How can New York State educate the public regarding sickle cell disease and the benefits of early detection? How can New York State establish a statewide public health education and outreach campaign to publicize events based on sickle cell disease screening, detection, and education services? How can New York State develop healthcare professional education programs? How can the council consult with patients with sickle cell disease, their families, healthcare providers specializing in sickle cell disease, and others to produce screening, prevention, and treatment information? A couple others you mentioned to a lesser extent, which may be applicable here, but we also may be able to address these by different means. When I asked you all to consider what else you might like to be addressed in these listening sessions, you stated, how can we engage patients and families in community education efforts? What are we missing? What should we be considering that's in our blind spot? How can the council be more helpful in messaging to the commissioner and other Albany offices? And we may need to educate our audience on what community listening sessions are. They may not know what it is going into it. In terms of what council members identified that they could contribute to our community listening sessions, many of you indicated that you can help to advertise and recruit participants. A few of you advised that you would be able to help secure a location to host community listening sessions, help with event planning tasks, facilitate a discussion at a listening session, help to create a report of our findings, identify individuals or organizations who may help to plan sessions or assist with session activities, and explore opportunities for funding session and related activities. Though at least one person indicated that they could help in each area, we received fewer responses regarding your ability to assist in documenting responses and following up with participants. As we move ahead with planning, please keep in mind some of these tasks may be addressed by other staff members you can bring to the table. The whole lift doesn't have to be on the council members alone. Additional considerations as you wrapped up your surveys include that it's important we solicit rural voices and we keep in mind the current political climate in our discussions. Otherwise, I've noted the organizations you all have collaborated in the past to support listening sessions, and DOH is looking to identify community partners as well. We'll have to let you know what we're able to find. And before I pass the conversation off to Sue and the discussion that she brought, do you, Sue or Wilma, have anything you'd like to add, emphasize, or clarify about a listening session from DOH?
Traditionally, the listening sessions have been a really good opportunity to hear directly from the community who is impacted by this. And I think it's important that their voices be literally and physically at the table so that we can learn firsthand how to best move forward. And so we look forward to those opportunities when they present. Thank you.
And I can add that DOH does listening sessions often, and we're actually in a cycle right now where for our Title V maternal child health funding, we are in the year where we do a statewide needs assessment that involves a lot of listening sessions. We also did some listening sessions with our children and youth with special healthcare needs program very recently. And then we did a couple with our sickle cell, which
Sarah
contractors,
Barrento,
which I'll tell you about in a minute.
Stephanie
But we also
Gagnon,
have an active adolescent mental health campaign where we're
Virginia
doing
Sack,
listening sessions with
and
youth.
Suzanne
So I think what we can offer is lessons learned from those most recent listening sessions as you all are going into this process as well.
I think one of the things we need is more people that look like some of my people to be on
Should I
these
keep going?
Okay.
platforms representing for us, speaking
I
about the
think that
disparities that we
need to
face.
consider
I don't think we have enough of that.
the clusters of demographic clusters of where people living with sickle cell are located. When I got the survey, just for the sake of it, I started asking the patients that will come to our mobile clinic because it really is a very diverse group from 18, 20 different countries. And we just asked the question, by the way, have you ever heard about what
I love when they
sickle
say it's a
cell
very
is?
diverse group, but all of their participants always look like them
Probably
and not
3 or
like
4
us.
people out of 100 knew what it was. So I think it's important that part of education, and you mentioned it in here, that it's important to know what it is so we can recruit with the proper people. And the other thing that I will keep suggesting, in the number of participants, when you have a large group, it tends to go in a different direction than that intended. So for a sickle cell, for this topic, I will have around 20 people, not more than that, because then you may start creating some anxiety or why this population and why not my population. So yes, but it's very interesting, and thank you for doing such an extensive research and for bringing those findings to us. Thank you.
Thank you.
Any other comments or questions for Alice before we move on to Sue? Sarah?
Hi, yes, thank you. So after we got off of our group, I really started thinking about one area that we didn't talk about, and that was the structure of the listening sessions. And I found that, so as Suzanne, when you were talking about the maternal child health, public health director in Montgomery County, so CHIN, all those programs, one of the things that I find is that we need to be clear when we are setting up the structure that this is not a support group or a therapeutic environment. It is really a data collection and making that clear that this is not a support group in therapeutic services, because I think sometimes when we do listening sessions for other programs, it really does derail the purpose of the group and they can go off the tracks really quickly. So I thought about that afterwards and I just wanted to bring that up. Thank you.
Good comment. Yeah, it's a good observation. Any other comments or questions for Alice before we move on? Okay, Sue, if you are ready.
Yes, sir.
Great, thanks.
Yep. Hi, everyone. So as we probably talked about the last couple times on this meeting, the Bureau of Child Health did host 2 stakeholder meetings, listening sessions, whatever you want to call it. They were quite small, but extremely informative. We asked them about, these are experts, either providers or allies or those who have sickle cell disease or have families. So we were kind of just garnering their expertise, experience, and their perspectives. And then Christina Usack from our Bureau of Child Health compiled everything and condensed it. And that's what I'm going to read to you today. So I'm literally just going to be reading off. We categorized it and grouped it, and I have bullets in front of me. We will share this in some form with Wilma and Alice. so that they have kind of all the meat that can help Alice synthesize things in combination with everything she's getting from you all as far as what those recommendations ultimately are going to look like for you. So I will say that there weren't many surprises. I did have to Google a couple things like, what was it, electrophoresis? But everything else was pretty straightforward. And I just want to point out a couple of key words that came up multiple times over and over and over again. And this is just in the condensed version, right? This isn't the full script of the meeting. So obviously trait came up a lot. Education came up a lot. Immunization came up a lot. And you'll see why in a minute as far as record keeping. Let's see, information, stigma came up a few times, reimbursement, discrimination, kind of in the same vein, discrimination and reimbursement as far as having public record of immunization, adolescents, insurance, support, increased funding. So those were the, I went through my little cheat sheet here. I know actual paper, I'm sorry, but, and just kind of underlined words that repeated so I could call those out before I started, and you will hear them as well. And I also apologize that I was not on at the beginning of the meeting. I was trying to do double duty in another meeting, and Stephanie was like, nope, come on. So here I am, and I will not do that next time. Okay. So we start with screening and early detection. And let me just pull up so I can read. Okay. Improve education for sickle cell trait patients and their families, including referral to hematology. Ongoing education for children is vital, especially during adolescence and early adulthood. As they enter reproductive years, it's important to know their sickle cell disease and or trait status. That came up frequently as well, not just trait, but trait status, know your status, that kind of thing. And one recommendation was education and reassessment with a hematologist. Offer electrophoresis to parents of trait babies. Record sickle cell disease and trait status similar to the way immunizations are recorded. So in NICES, so it's, I'm adding to this, I'm ad-libbing now, which I probably shouldn't do. NICES, which is the statewide immunizations record. For example, have trait status or sickle cell disease listed on their medical record and immunization record. Screen men and male partners. Obstetrics and gynecology screen women, but not the spouse or the partner. It's best to identify trait status before pregnancy occurs so that both parents are aware, similar to cystic fibrosis testing. Then the next group we categorized as public education and outreach. So public campaigns should reach people where they are, such as on the sides of buses, bus shelters, along the lines of get tested, know your status. Public educational materials should be provided at schools, libraries, houses of worship, etc., with diverse messaging language. The community should be included when developing messages and campaigns. Utilize social media and other paid media services. The next one is establish comprehensive sickle cell centers, phone hotlines, QR codes, so people can readily find information and education, and provide more education to parents and caregivers of sickle cell trait patients, meaning a uniform informational handout or website, and address the stigma associated with sickle cell disease. Next category we determined is education for healthcare providers. So mandatory education related to sickle cell disease and trait should be required in emergency medicine, internal medicine, and pediatric residency training prior to graduation. Educational informational sessions should be provided for primary care and emergency room physicians on a recurring basis. Sickle cell disease patients are seen in all areas of the hospital, and many providers will encounter a patient at some point and have the opportunity to make a positive impact. Consider using a hub and spoke model to address the limited number of providers in adult hematology. Subject matter experts, meaning sickle cell disease hematology providers, should partner with other providers to take calls and provide consultation and recommendations. Sickle cell disease hematology providers should be visible and easily accessible to other providers. If a sickle cell case presents in the ER and a provider is unfamiliar, there should be clear steps on what to do next in a guided manner. So that sounds kind of like a protocol to me, which we don't use here, but
There needs to be a protocol. That's a fact.
the same should be available for physician offices in the community.
If somebody comes in with a gunshot
Information should be
wound,
available
protocol.
regarding
Cancer,
specialty
protocol.
centers for
Heart
patients
attack,
and
protocol.
where to find
Sickle
those
cell,
resources
no
and
protocol.
information.
Tell me about it.
Next is counseling and referral services. Standard screening at the primary care level for hemoglobin electrophoresis is recommended for adolescents and young adults so they know their status. For example, when completing sports clearances, drawing college titers, or providing immunizations. In the past, there were concerns related to discrimination and students not being allowed to participate in sports based on results. There has to be a balance between a person knowing their status and maintaining the confidentiality of the results. For example, recording the person was tested and counseled about the results, but not automatically reporting the results to other organizations as part of the medical record.
Violation of HIPAA right there.
It's necessary to counsel patients during adolescence and young adulthood regarding opioids, filling prescriptions, misuse, abuse, addiction, and side effects.
That's your Fourth Amendment.
Health
right to privacy.
educators should be contacting and offering in-person counseling for all babies who have trait, for the parents, and offer telephone counseling with mailed information packet if the family is not willing to come in. And I put a note to myself here that all families should be getting that packet, even if they do come in. Funding needs to be available for sickle cell disease initiatives, including trait testing and counseling. And make sure sickle cell patients can access insurance and aren't denied or stigmatized. Patients need to be aware of where they can go to get tested, whether they have insurance or not. Okay. Promoting health and quality of life and improving the system of care. Mental health support is the most important component. Break the barrier, destigmatize these services for patients by including a mental health provider as part of the care team, along with the nurse, social worker, physician, etc. Patient support groups for tweens, teens, young adults, parent support groups would promote health and improve quality of life. Supportive services such as care management, transportation, childcare, etc. is important to families, especially those affected by poverty and other social determinants of health. Provide a mechanism for reimbursement or mechanism for fund generation through our value-based payment systems or the medical home. We need to have a standardized testing schedule, meaning what tests need to occur yearly, biannually. That is an evidence-based initiative or policy. Utilization of telehealth so the patients are close to their support system and provider base. Work with Medicaid to improve reimbursement rates for providers, not hematologists, who take care of sickle cell disease patients. Last one is data. Provide the number of people and demographics related to those living or diagnosed with sickle cell trait in New York State, and the number of people living with sickle cell disease. Include data related to transfusions, hydroxyurea, and transcranial Doppler. Numbers give us power and show where services are needed and what kind of services are needed. Having data can support research focused on sickle cell patients and increase funding. There aren't enough adult hematology providers. Data should be made available to internal medicine programs, but also hematology oncology programs and internal medicine conferences in order to leverage and improve the reimbursement rate for the physicians. So that's all I have as far as written. Are there any questions, comments?
Freddie has one. Hold on.
I'm sorry, but I think that the big challenge in here, it will be with the providers of care. Because for the last, I don't remember the last time that I went to my doctor, he mentioned anything about sickle cell. And while we were working at the Federal Qualified Health Center, it is the same story. So we have so many boxes to check and so many other things that I agree this is something that needs to be a priority, and maybe starting in the medical schools or residency or fellowship programs, it could have a bigger impact. But as of now, I don't see that as part of anyone's major interest. And I think that the education about what sickle cell is needs to start at all levels at the same time, where it's public campaigns in the subways and the radio, TV ads, as well as a dear letter with the medical directors, with providers, internal medicine doctors, because we don't want to create another entity, but rather do that as an integrated part of care, medical care.
I agree. Don't create another entity. I know people want to think that's a great thing, but all medical just needs to work together.
Any other questions or comments for Sue? Okay, good, great. Thank you, Sue.
Okay.
So that leads us to looking at what would be the timeline and the utilization of evidence, and that both Sue discussed, and the information we get from our community listening sessions in creating a timeline for our report that's due to the commissioner by the end of 2025. I'm not sure how much discussion we're going to have today. We don't have a quorum.
They almost never have a quorum. A lot of these meetings I go to almost never have a quorum.
Is that
things are always delayed because they're not on point. There needs to be a requirement for a quorum. You must attend this amount of meetings. You must be present. You must be able to answer if you're in a video call. It must be undisturbed. The camera's on. Because things fall through because quorum is not met by too many individuals
Could we
who
have an
took up
ad hoc
these
meeting,
positions.
because
If you cannot uphold a position,
we
don't
only
take it because quorum is very important.
We are running the timeline. Now it's March. Before we know, it will be time for us.
until June.
Yeah, and the summer months, so maybe we should have an ad hoc meeting. And just do it because we need to do this.
Yeah, and what we could do is that when we come up, like maybe we three will have a meeting just to sort of get it all framed out, and then we'll call ad hoc meeting via Zoom, and then we can go through the timeline and go through the draft of it, and then so that way then by the time we come back in June, it's really more for a formal discussion and then a vote on the timeline. That's a good idea. Anything else about sickle cell before we move on? Okay.
Yeah, I just want to check because there was a little overlap. Alice, is there anything else that you wanted to share from your presentation, or you're good?
I'm all set, but
Okay, thank you.
Yeah.
Good. The other thing that we'll need to discuss when we have a quorum are the goals that the council laid out last year. Sickle cell, of course, we have to work on, and then also they spoke about AI and women's health. So we'll need to tease those out and see who will sort of be the champions of those two other goals for the council, and then create a timeline for what activity and events will occur for those by the end of 2025, just so that they're not hanging there for the next year and nothing's done with them. We are just skipping through. I'll yield to people in the room if we need a break, but I think we're okay, correct? Okay. Okay, so from what we discussed today, that we'll have a meeting with Alice and Wilma and I, and we'll discuss the draft timeline and some options with it. Then we'll call an ad hoc meeting for the council via Zoom. So that way then when we meet for our June meeting, that we'll have some actual items for the timeline for a vote. We will also have to vote for the minutes from December at the next meeting since we didn't have a full quorum at this meeting. Our next meeting will be on June 13th in Albany, so we can plan for that to meet there and hopefully have a quorum. And any questions or further discussion before we move on to the public comment section?
I wonder if they're going to see my comments.
Okay. Do we have any questions?
Yes, we do.
Okay.
So, yes, with lightning speed, we have moved towards this. And I want to thank the council members who are participating today. Thank you very much. So here are the questions, and I'm hoping that Sue's team will hop back on.
So I love they're going to pick and choose whose questions they want to answer.
The first
Who wants to
question
answer
from the
mine?
public comment is, how can we ensure that patients with sickle cell are being treated equitably in the ER, as too often patients are neglected and left unattended for hours, if not days?
That's one of my
with a
questions.
condition that only worsens the longer we stay in a crisis? And how do we hold professionals accountable for not taking
Who
care
would
of
be reading my
patients
question?
and following company federal guidelines?
They're not going to answer my
Wilma,
question?
that is far beyond my expertise. But I can just, what I can offer there is a pivot, which is to say, to include that provider education in our recommendations to the Commissioner of Health, and perhaps not limit it, right, to our ER physicians, to our medical schools. There needs
I'm going to
to
ask the tough questions they don't want to answer.
probably be more hands-on training, hands-on education
Because as
for
they
all
are the Department
providers
of Health,
of all
they
levels,
should know how to hold people accountable for their actions. They know how bad sickle cell is, and the fact that this is
throughout
their
their
answer,
careers.
I'm really not happy with their answer because the Department of Health oversees the hospitals.
So I think it'd be interesting, and I'm not sure how we would coordinate this, but if there's some way that the department could work with NICET, just from all of the physician assistant programs, NP programs, med schools, osteopathic schools, it would be interesting just to get an assessment, even if it's just a quick Qualtrics survey somehow, of what content they are currently teaching or preparing them. I think that would give us an interesting baseline for that, because I wonder if a lot of program directors know that.
Right. Yep.
But I'm not sure who the
So-
contact would be at NICET to sort of help us with that.
I think it's a great idea. Maybe we can add the nurse practitioner schools. I believe that the nurse practitioners normally tend to be a little more focused with the patients than many of the providers today. And we've seen it's a growing population of clinicians. Nurse practitioners somehow are, I don't know, I just feel more comfortable with them in many areas because they really spend the time with the patient and they are more intuitive. So maybe if there is an association of nurse practitioners in the state, do, like Mario says, small survey of how is that included in their curricula, as well as the schools or hospitals or fair qualified health centers that are hosting now residency programs for the community.
And maybe from a physician or hospital-based perspective, we can tap Helen to see what recommendations she might have. The next question, or it's more of a comment, I think. Even when made aware of the malfeasance that were conducted by negligent
This is my
professionals,
question.
our cries as sickle cell fall on deaf ears, even though under 42 USC 1986, they have an obligation
my
to
question.
prevent neglect once made aware.
Answer my question.
Okay. The next comment is,
Nobody wants to answer that.
since the implementation of the VICP and CICP, the numbers of negligent situations have increased as doctors and other
This
health
is my third
professionals
question.
are protected by a void ab initio established immunity.
Oh, they don't like my questions. All three of those were mine.
When a patient with sickle cell disease says, I have a 50% chance when I go to the hospital that someone will be nice to me, how are we addressing that experience?
So they don't want to answer none of my questions. I told you, I'm not making it easy on them. But the fact is, they were all just made aware. 42 U.S. Code 1986. Read that law. It's out there in the public. They can't say they didn't know at this point.
See, Wilma, I think that the last comment, I think it is, could be not intentional, but I think that it points out at the lack of knowledge from the part of the clinician. And because if I had a particular condition, I'm going to assume that if I go to a medical facility, everyone should be familiar with the condition, but it's not the case. We know that it happens in many, many other illnesses. So maybe that's a good comment that we can use as when we talk to the clinical or educational facilities for clinicians. And it's very powerful. 50% chance that someone will be nice to me. That will deter me from going there, because if it's one of the days that I'm having a crisis with my condition, I'm not going there.
Right. And I so agree with you, Freddie. You know, we're not going to go where we're not made to feel welcome. You know. Right, so thank you. This is the next question. I defer to you. I would like to discuss a patient experience form that I have developed to change the culture of health systems towards individuals with sickle cell disease.
To me? Well, this council only makes recommendations to the commissioner. So there's a couple of options, is to send it, I guess, Sue, is there a general email at Wadsworth where someone could send information or reach out to discuss a possible assessment or eval tool?
I'm not sure where that would end up.
Of course not. Why
My
make
program
communication
is
easier?
non-clinical.
Right.
We're only a youth transition program. But
Right. I'm not
I
seeing
could
anything
certainly-
yet. Yeah. I'm not seeing anything yet, even in the information that you outlined today, Sue, that there was any discrepancies in the assessment or evaluation process. It was really more about getting people access and moving them through the system and keeping them connected so that they can manage their symptomatology. But I didn't hear, unless I missed it, I didn't hear anything that patients and their loved ones thought that the assessment process was somehow difficult or broken.
no.
Okay. So we can find an answer to this, and then, well, right now, it doesn't seem to be the top priority that for us to work on that. But once again, this council only makes recommendations to the commissioner in light of the legislation.
Thank you. This is the next question. And it appears it may be the final question, however, let's see. All right. I feel like going to the doctors is a waste of time and energy, as it seems that the doctors nowadays just brush through their cases instead of taking their time to help, instead of taking their time to explain how to help. Maybe it's burnout, lack of passion. It doesn't make me want to trust my provider.
Yeah, I think that's,
So-
go ahead, Sue.
I was just going to speculate, which I, of course, hesitate to do ever, never mind in a setting like this, but I do think that some of these comments can be very easily rolled up with the feedback that we've received so far and into that provider education piece, but also based on the last comment, perhaps the reimbursement piece as well. That if there's more reimbursement for services, for screening, that it would be easier to fold those into a visit.
Right, I was gonna suggest the same thing, and then I would add, it'd be interesting if we are going to reach out to educational institutions about the content, maybe just have a question or two about the evaluation or guiding of young physicians and NPs and PAs in terms of like what's their model or philosophy in terms of patient-centered care, person-centered care. I mean, something so we can sort of tease out, when people say things like that, I think about, well, they could have been educated in one way, but the practice environment is pushing them to act differently, right? Right. So it'll be interesting to know if we get a lot of feedback about, yes, we teach our students patient-centered care, listening to the patient, but then we're hearing that that some of the constraints and challenges in practice are driving providers to act in ways that aren't consistent with patient-centered care. So, I'd be curious to sort of, hear that. Is that the last one? Okay.
I added one more, but I guess they're not going to read it. I asked, my last question was,
The complaint form is not about the disease, it's about the treatment of individuals with the disease. Can you state again where I would send the form?
I asked, why is it that doctors can use hospital policy instead of
Mario, I
listening
think
to
you said
federal
that
law,
we
like the
would have
Patient's Bill of
to
Rights?
take that back and figure out where that would go.
Correct. We had to find out where within the department that would go so that it just doesn't get quote unquote lost.
Mm-hmm. Right.
Yeah, at least as a start.
Okay. So what we can offer is the general email address as a start. That's omhhdp@health.ny.gov. All right, here's the next question. Why are doctors allowed to use hospital policies instead of following federal guidelines like the Patient Bill of Rights to facilitate care?
That's my fourth question.
It's hard to answer that why question because we're not sitting in that practice setting and we're not sitting in that provider's shoes or practice environment. And so, there are federal guidelines and Patient's Bill of Rights that everyone follows. But what's unique about the practice of any health care in any setting is that every state, jurisdiction, county, and then hospitals have policies that reflect and integrate the Bill of Rights, but they do it all in their own unique ways. They have to be consistent, but they don't have to be the same. And so
They do have to be the same. That's a violation of the 14th Amendment.
It's, sometimes.
Because the 10th Amendment gave the
easier
states and the people
address
the right to make
the
any
what
decisions,
or
but the
how
14th
of
Amendment
something
directly
as opposed
stipulates
to
they
the
cannot
why.
make
So
anything
it's
that abridges the
general,
rights
but
of the
that's
people.
generally how the
So
Patient
if
Bill
they
of Rights
make
plays
anything
out
that
in
abridges our
practice.
rights, it's void ab initio. So they have to still follow federal policy.
To go back to the primary care question, is that part of primary care, or are we making sure that it's part? I'm not sure that it's even in the curricula or in the elective courses that people take during their fellowship or residency. So I think that we really have to make a strong case that it's sickle cell should be taught, should be part of that one because it has effect in perinatal care, in adolescent medicine, and in adult medicine, obviously. But I'm pretty sure that even in my own agency, if I go ahead and do a survey, very few people know that it should be part of the questions to ask. And I think, again, not blaming, not pointing fingers, but the hospitals and the Federal Qualified Health Centers today are being forced to see like a mass production numbers rather than the care. And that's when we have, we're trying to say in my agency, let's go back to the basics, but better.
Right.
Because we really need to practice medicine, not just commercial when you're only allowed 20 minutes or 30 minutes with a patient and move to the next.
Right.
Yep.
Why do patients with sickle cell disease now describe themselves as sickle cell warriors? What does it say when
Before
an individual human
2020,
being is potentially halfway
were
through their life expectancy has to be a warrior? Cystic fibrosis or leukemia patients don't have to be warriors.
And
Frankly,
as
it's because they are
children.
African American.
These guests.
And again, I'm not sure if there's an answer to that, but I think that could go part of into the
Sickle
data
cell
issue that even your group has
warriors
been
acted like
collecting in terms of the
advocates.
the patient experience that's tied to
for
living with
us
sickle cell
when
is real, and we keep sort of hearing the same
speak.
theme now of that they're having difficult experiences. They
And
feel
took
discriminated against.
action
They don't want to go because of
when we
past experiences,
were
and then when they go, they're not
left
getting the quote unquote from their
alone.
experience the proper or appropriate care that they should have. So I think that's telling. That's one reason why we wanted to do the community listening sessions, was that to see how our policies are actually carried out in practice for the people that we serve in New York State. So I'm finding that was the third or fourth time that something like that was mentioned. So that's why I was curious about how students are being educated in what environment versus when they go into practice, the practice environment shifts all that because of demands.
So Mario, can I add to that?
Oh, sure.
So just in terms of what we've learned so far in this process, I'm gonna correct myself a little bit. And when I was talking about reimbursement and provider education before, I think this also comes back a lot to the public education, the public campaign. So the more angles that we address this issue with, the better.
Oh, sure. Oh, sure. I agree. Because, part of it is also knowing, and, to Wilma's point earlier, is that
I'm telling you, I hire
if they
me
do have a bad experience,
to sit at
but
these
they
seats and
know of
represent
other
us.
places to get
Because
care,
I'm bringing laws against them.
then they have options for a lot of times.
Constitutional
If
laws
they don't
against
even know
them.
other places to
I'm
get
telling
care,
y'all,
then they feel like
if
they're
any of you
stuck,
can
so why
get
go
me in
back
a
to the
seat
place
where I can
that
speak
didn't
at these
have-
conferences,
have
where I can
a good
speak in front of the
experience?
president,
That's a
speak
good
in front of
point.
these people, I'm
And
going to
if
hold
we
them
can do it
accountable.
at the same time,
Forget the immunity, uphold the law,
more
and
effective.
take care of the people.
Like last
Because these people
night,
here,
this
some of the stuff I'm
days when I
asking, they don't
see
even
those
know these
commercials
stuff.
about
Title 42 U.S. Code
secondary
1986,
smoke,
failure to prevent neglect. They don't even
and,
know what that
different
is.
type of
They just read it and
commercials
skimmed
about
over it.
smoking, about cancer, about
I have sickle
children,
cell,
about the
and I'm
impact that
studying
they'll
law.
have
I don't know a lot,
in the
everything,
family.
but I'm still studying.
And I
But I'm
think that
guarantee you,
people
I'm going to
start
speak up a
talking
whole lot
about
more
it,
than
and
they
people
will.
say, wow, that commercial stuff. And I see that in the subway stations. So I think it's very important to conscientize the public, the medical community, and the elected officials at the same time, so the impact will be bigger and more effective.
One more question. Before 2020, we were allowed guests in the emergency room
That's
at
my
all
last.
times and as children. These guests for sickle cell warriors acted like advocates and spoke for us when we couldn't speak and took action when we were left alone. Advocates and guests need to be allowed 24/7 with a man or woman who cannot advocate for themselves.
That's my last comment. You got to say
Right, and
about
that'd be
that.
interesting to hear, from someone, in healthcare agencies or in leadership about how those policies are carried out. From my understanding, in general, a lot of healthcare systems if you ask, they will allow you depending on what the unit is. If it's ICU or critical care, that may not be 24/7, but if you ask for more access, they usually give it to you.
No,
Maybe
they
you should
don't.
just
We
see what
ask for
other
access all the
healthcare
time. I
leaders
ask for access. They tell us no all the
recommend.
time.
If one is in crisis, they will go to the closest hospital as their pain is off the chart.
That's true, I would imagine.
Yeah.
I see where you're going, but you should have finished that question. If I was in, we need to sometimes go to a
Those are all the
specialized
questions
hospital
at this
or
time.
see our doctors that we can directly get answers from, not just be sent to the nearest clinic.
I would
You're not
say,
going to send a
that
victim with
probably
a
concludes
heart
the
condition,
meeting.
with heart trauma,
Any,
to a hospital that has no
do we
clue
have
what to
enough
do with
to
heart
go
trauma.
further?
You're going to send them to a location that knows
We
and
don't have a
specializes in their
quorum.
situation. So when the ambulances tell us we can only take you to the closest one,
Anything you want
that
to
is
go
not
through?
beneficial to
Well,
my health.
I'm on.
Take me to a hospital where I know
We don't see you,
specializes in my
Helen.
condition, so
I'm
I
right
can
here.
get better
Oh, wait.
service. Yes, it might be further,
don't
but
know
that's
how
what
to
we're
put the
paying you
camera
for,
back
to
on.
take us there. That's what these insurance is paying you for, to take us where we have to go.
Why is this
And
still
if
not showing
insurance
me?
doesn't,
Oh,
then insurance needs to be
there's a
held
little
accountable for
flap
that as
thing.
well
Oh
too.
my gosh.
Sorry about that.
Helen,
They
I
had to
don't,
like reboot my whole hard drive. They had to put a new hard drive here.
Do you have any comments before we sign off, Helen?
Now, did we make quorum now with me?
No, I don't think so, no.
the only council members that have participated are Freddie, Sarah, and yourself.
That's 3 though.
Yeah, that's not a quorum.
Yeah, you never make quorum. Quorum is the minimum amount of people they
I
must
thought the
have
quorum
before they
with
can
the new
pass a
bylaws
vote.
was 3 or more. Oh, no,
No.
3 and more. And we need one more. Yeah. Sorry, I tried.
No trouble.
You
there's
didn't try to
Albert,
get
though.
enough. You should have been on from the
I'm
beginning. It's
here.
an important topic, but clearly it's not that
So we
important to
may
you.
have quorum now.
Would he be the 4th?
Yeah, yeah.
Hi.
So,
Hi,
so-
this is Tandra, I'm here.
Oh, so that's 5.
So
we do have a quorum.
come on at the end.
Just go
Where
ahead.
you heard nothing about the
Have we been
discussion
having
and that
technical
vote and stuff.
difficulties because we haven't seen anyone?
Well, I had my hard drive from, it burnt or whatever it did.
So as
they
professionals,
have to
we
put a new
look
one.
into these problems
Oh,
when they
okay.
happen.
But that's how.
We're having,
Right.
That's
we're having a
horrible.
terrible windstorm here, so if I keep flapping in and out, the wind here is like terrible today, so I apologize, but I have been here and I've been able to see you and hear you,
Okay.
but you have been coming out on my
Yeah.
end as well,
Thank
so,
you.
but I'm here.
Yeah, we've seen you, Sarah, and so probably what we'll do, I'll still postpone the voting until next time, because per the guidelines and the processes, all cameras have to remain on for the meeting for them to be counted
okay.
as present.
Yep,
So
camera has
then
to
we'll
be
just
on.
do it at the June meeting, we'll do all the voting, that's fine.
And our June meeting is in Albany, correct?
Correct.
Hey,
Okay, I
anybody wants to
apologize. I've
sponsor
been
me,
here.
I want to go to Albany
I
and
wasn't
speak.
aware.
If anybody
Just
wants to pay for my transportation and pay for my hotel, let me know. As a
So
public
technically in
official,
attendance, it's been Sarah and
they
Freddie.
don't know that they have to have their cameras on? Come on. These are the
Because
people who are
everyone
making
else didn't
decisions
have
for us.
their
They don't
cameras
know
on.
their cameras need to be on. They don't know they should be at these meetings. This is ridiculous. These are the people
So
who we're
with that,
leaving
I will
to.
just call the
handle
meeting to
our
order,
healthcare.
and then we will see you all. We'll be
Not
having
impressed.
a ad hoc meeting be-fore the June meeting, so we can go over the timelines draft, and then we'll vote on it at the June 7th meeting. Okay? So be looking for that. Well, great,
Thank
thank you,
you.
everybody. Take care, bye-bye.
Thank you.